Hi, my name is Dominique, and we'll be talking about maintaining optimal nutrition in the ALS patient. I'm assuming now everyone's kind of in the middle of their food coma after lunch, after their cookies, so I think now is probably a good time to talk about food. So what we're going to do, we're going to discuss the role of the dietitian. We're going to discuss nutritional barriers and interventions within the early, middle, and late phases of ALS. We're going to discuss ways to monitor nutrition status, and we're going to discuss common misconceptions. Do we have any dietitians in the room? Yay, welcome. So we have, no, higher this. It's a commonly asked question. What's the difference between a nutritionist and a dietitian? So anybody can be a nutritionist. Anyone can claim the title of a nutritionist, but not everybody's a dietitian. So to be a registered dietitian nutritionist, you actually have to complete, well, we are the food and nutrition experts who have met the academic and professional requirements to earn the RDN credentials. So that means that we finished an accredited school, we go through an internship, and then we sit for a national exam. After that, we have to continue to do continuing education. So, and within the past 6 years, previously we were registered dietitians, and now we have the title of registered dietitian nutritionist. So how does this play a role in ALS? So nutrition plays a significant role in patients with ALS, as the deterioration in nutrition status negatively affects the disease course and survival of patients. Poor nutrition status is an important prognostic factor, as malnutrition can exacerbate muscle weakness and impair respiratory and immune system function. So throughout the day, we've kind of talked about all these different complications and how they relate to the different disciplines. So, but we want to talk about how this relates to nutrition. So let's talk about the lunch that we ate today. Everybody got the salad, or we're gonna at least tell the dietitian that we got the salad. We had the sandwich with some sort of protein on the inside. We had pasta, and then we also had, I believe, cookies were available. Is that right? So not all these complications, our patient population don't display all these complications, but some do. So let's talk about someone with dysphagia. That lunch, possibly, I wouldn't be surprised if someone came into clinic and they told me that they couldn't eat the salad, that the salad's too hard and that's something that's hard to chew and swallow. In addition to that, the bread for the sandwich would have been too hard to chew and swallow, so therefore they probably would have only been able to eat the inside, whatever that kind of contains. The pasta most likely would have been fine because that's soft enough to chew. And the cookies, depending if they were softer cookies or if they were harder, maybe they'd have to be kind of dipped into some sort of liquid. So you can already kind of see, based on what you ate today, how that differs and what kind of challenges those patients have. Fatigue. Maybe we took 5 to 10 minutes to finish our lunch, kind of depending on if you're chatting and other things. In clinic, people come in and, I mean, some patients tell me it takes them 35 to 40 minutes just to finish one meal. So multiply that by 3 meals a day. That takes a really long time just to sit there and complete a meal. And a lot of times these people say that they're tired and they don't even finish their whole meal because, 15 minutes in, they haven't finished, they're tired, and they don't want to eat. Hypermetabolism, so you have an increased need for calories. So let's say your lunch now was 400 calories, and that would have been okay to maintain your weight. Those with ALS might need 600 calories. I'm just throwing out, generic numbers, but you need more calories during your meals. Or the upper limb and motor difficulties. Someone maybe would have had to come and plate that meal for you, or they would have had to feed you. So all those things that we kind of did today, we had a sandwich, we were able to chew and swallow, we were able to kind of feed ourselves. Patients come in, they show and display difficulties in that, and that's kind of things that me and Julia kind of discussed to kind of help with those different complications.
All right, so getting into the meat and potatoes of our presentation, I'm going to be talking about the early stages of ALS, some of the barriers, and then the common interventions that we provide to our patients. Research in both rodent and human studies have found that ALS increases resting energy expenditure, which means that a patient needs to eat even more calories than normal in order to maintain their current muscle mass and weight. Research has found that the high-calorie, high-protein diet may stabilize muscle mass and weight and potentially improve prognosis. As chewing and swallowing become more difficult, it can lead to fatigue, prolonged meal times, and further reduction in oral intake. Fatigue due to muscle weakness and decreased respiratory status can further decrease appetite and desire to consume adequate intake. During the early phases of ALS, we began to review the high-calorie, high-protein diet and recommend to avoid patients consume low-calorie foods that can be too filling. So for example, 100 calories of broccoli is 2+ cups of food, which can take up a large volume in your stomach, versus 100 calories of peanut butter is only about a tablespoon, which takes up a lot less volume, which allows the patient to eat more calories in order to maintain their muscle mass. We encourage the incorporation of higher calorie, softer, and protein-dense foods, such as 2% or full-fat dairy, nut butters, avocado, or butter or oil on top of their carbohydrates, such as rice or potatoes. We also begin to review calorie and protein targets so that the patients and caregivers have an idea of how many calories does that patient actually need in a day. During the first few visits, we also start to discuss liquid calories in the form of oral nutrition supplements and smoothies. When it comes to smoothies, a lot of times people are making them with almond milk, maybe a handful of spinach, maybe a frozen banana. It's not a lot of calories, doesn't really have a lot of protein or a lot of fat. So I'm working with a patient to discuss how we can make that smoothie more balanced and nutritionally complete in order to simulate a balanced meal. So maybe that means including a protein source such as Greek yogurt, protein powder, pasteurized egg whites, or including a fat source such as avocados, chia seeds, or nuts. We also review supplements that you can buy on the market, things like Carnation Instant Breakfast, Ensure or Boost, Orgain, Adwala Protein, Premier Protein. Kind of depends on the individual patient, what they like, what they desire, and what meets their nutritional needs best. During this phase, we recommend that the patient start to consume maybe 1 to 2 supplements per day, but this is also dependent on their current weight and their current intake. Immediately following a new diagnosis of ALS, a patient may not experience any of these symptoms. During this time, we discuss the importance of weight maintenance and continuing to maintain a balanced diet with good oral intake. And typically, we discourage weight loss within this population because evidence has found that calorie restriction induces faster onset of clinical symptoms and shortened lifespan. So as ALS progresses, the barriers and interventions continue to evolve. So as dysphagia worsens, we start to collaborate more closely with our speech therapists. They provide good insight into textures and consistencies that are best tolerated for their patient. So like Kristen was saying earlier, sometimes they're coming out of the room and saying, hey, this patient can't tolerate bread anymore. What other carbohydrates would you recommend to them? Or maybe water's becoming more difficult. How are we going to be able to help them maintain their hydration? Typically, softer moisture foods are best tolerated, and anecdotally, I've found that typically patients are starting to begin very carbohydrate-heavy meals just because those items are inherently softer. So mashed potatoes, soft cooked pasta, applesauce, oatmeal, pudding. So we need to work with them on how they can augment those foods in order to bring them up to protein and fat goals. So examples would be adding ground meat to that pasta sauce, so it's still soft and able to swallow. Including peanut butter in oatmeal, or adding cheese and butter to grits. Other softer protein-dense and calorie-dense foods we recommend are tuna, chicken, or egg salad, hearty soups, and Greek yogurt. Other ways you can augment food to make it a little bit easier to swallow is blending an Ensure with a frozen banana, or adding ice cream to it in order to make it a little bit thicker and easier to swallow. As secretions accumulate, it may become more difficult to consume foods. Increasing fluid can help these patients manage their secretions. However, thin liquids may become more difficult to swallow. So working with the patient to figure out what are some naturally thicker items that they can consume. Milk, fruit nectars, maybe an Ensure, a Boost might be a little bit thicker, or if they want to use one of those commercial thickeners under speech therapy supervision. As tolerated, we encourage patients to consume foods that are inherently hydrating. So canned fruit, cucumbers, and celery as tolerated, or soups. As meal preparation begins to get more difficult due to fatigue, decreased ambulation, and limited dexterity and weakness, we start to also collaborate with occupational therapy in order to improve ability to self-feed, meal prep, and consume their food. We recommend including the caregivers in these interventions. Recommend loved ones come over to batch cook for the patient so that those items can be frozen in individual containers and the patient can take it out later to consume. Suggest caregivers loosen difficult to open lids and leave those kind of loose in the fridge so that they don't need to use as much strength to open it. Put canned items in easier to open containers. And then have the caregiver leave snacks and supplements within arm's reach so that the patient has high-calorie foods readily available to them. And then encourage the use of a straw in order to limit energy needed to take the cup to the mouth. As respiratory status worsens and time on non-invasive ventilation increases, there may be limited windows for time to consume adequate food. So we begin to encourage small, frequent meals, similar to 5 to 6 snacks per day. I suggest that patients use a combination of nutritional supplements like Ensure and Boost, as well as snacks. So an example goal would be consume 2 Ensure Plus and 3 snacks throughout your day for the next week.
And in the late phases of ALS, we see ongoing severe dysphagia, difficulty swallowing, hydration, dehydration, like we talked about throughout this entire presentation, and the need for enteral nutrition support. So as we talked about, the ALS patient may get a PEG tube placement. And when they get that placed, that doesn't necessarily mean that you completely stop eating and you're not allowed to take anything by mouth anymore. Many times our patients come in and maybe they still are eating 3 meals a day, they're snacking, they're taking liquids, but they're taking a little bit of supplementation through the tube. So maybe they'll do only 2 cartons of a formula and then they'll keep eating by mouth. As we continue to monitor them and as we see them in clinic, we watch for things. How are you eating? Are you having more difficulty chewing and swallowing? Are you getting fatigued with meals? Are you continuously losing weight? And as some of these complications may come up, we may see that you need to increase your tube feeding through the tube. So we always try to get a balance between what you're eating by mouth and what you're taking in through the tube. And it might come to a point where people may be only taking small bites of things, maybe taking a little bit of liquid by mouth, and they end up getting all of their nutrition through the G-tube. But those are things that we try working with the patient, with the caregivers, and we really want to meet their nutrition needs and help them with their quality of life as well, and help them figure out what's the best way to kind of get that nutrition, whether it's splitting up the meals or trying to find creative ways for them to get that nutrition within their day-to-day lives. Adequate hydration. I feel like everyone's mentioned how important hydration is for this patient population. Our speech pathologist did a great job about mentioning adding lemon, adding cucumber to water. If you have someone who's getting most of their hydration through the G-tube, what Julie and I like to actually do, when you come home, you actually get a syringe that is 60 milliliters or 2 ounces. And that's how the patient is administering their water through their G-tube. And when we talk about hydration, we actually give recommendations based on the amount of syringes, because that is a tool that that patient is using to kind of understand how much hydration. So if you're talking to a patient and they tell you that they're only taking 4 syringes of water, that's only a cup of liquid, 1 cup of liquid, and that is not enough hydration. Many times it has to be, close to 15 syringes of fluid. That's around 900 milliliters. So just kind of understanding. And that tends to happen too, that the patient might not understand how much actual hydration that they need, and that's something Julie and I discuss, is how much hydration is appropriate. Determining tolerance to enteral nutrition support and trouble feeding gastrointestinal issues kind of go hand in hand. We go through their day and we kind of figure out, are you bloated? Are you nauseous? Are you having diarrhea, constipation? And we like to kind of troubleshoot to figure out what's happening with those patients. So when we're monitoring, things that we're monitoring in clinic are oral intakes, and it's not just what you're eating, but it's everything that surrounds eating. So do you have new problems chewing and swallowing? Who's preparing your meals? Are you able to feed yourself? So those are things that we monitor for. Hydration, like we talked about. Weight status can be a challenge. So if you come in and you're losing weight, that tells us that you're not getting enough nutrition. but many times it's difficult to get a weight. Sometimes people aren't able to stand on the scale. Maybe we don't know the weight of the actual chair, or there's new devices on the chair. So we try to probe and use other questions to determine how to get away. So we'll ask things like, are your clothes fitting the same? Are your clothes looser? We'll ask family members, do they look thinner? Julie actually gave a great example. She was talking to a patient's wife, and last year they went to a wedding and he wore a tuxedo. And this year they're going to a different wedding and he was able to wear that same tuxedo and it fit great. And that kind of tells us that his weight hasn't changed and he's maintaining his weight. Other ways too are noticing any muscle wasting in your patient. So maybe they come into clinic and now their clavicles are really prominent, or maybe their face looks very thin. So those are kind of indicators too that you're not getting enough nutrition. Need for enteral nutrition support, like we said, we really try working with patients to meet their nutrition needs and kind of determine how much enteral nutrition support they need. Gastrointestinal issues and tolerance to enteral nutrition support. I probably can spend 2 hours talking about the various different kinds, but I'm only going to focus on two. The main ones that we see are abdominal bloating. A lot of times this can be for various reasons. Someone comes in with abdominal bloating and it could be a problem with their pump. Maybe the pump is running way too fast and that's causing them that bloating feeling in their stomach. Another reason for abdominal bloating, that could be if they're on a standard fiber formula. That formula has a mix of fiber, both soluble and insoluble. And what we've seen is sometimes people can't tolerate that amount of fiber in that formula, and that's causing that bloating. So we'll switch to a fiber-free formula to see if that can help with the symptoms. Other reasons for bloating actually could be maybe the breathing device is adding a lot of extra air into the stomach. And when that happens, venting the G-tube can help, just kind of opening up that G-tube and allowing some air to be released can help with the bloating. Also, constipation can help with bloating. Constipation can cause bloating, and that's the second symptom that we see a lot too, is people come in and they're constipated. My first question for them is hydration. Are you getting enough fluid? And we kind of go through the day to determine if you're getting enough fluid. Also, it could be a fiber issue too, so we kind of work to see, is it the tolerance in your tube feeding, and do you need a fiber-free formula because you're no longer tolerating the fiber formula. But I can go on and on.
So many patients want to do anything and everything within their power to decrease or cure their ALS. So many turn to complementary and alternative nutrition therapies. Above are some hot topics that are commonly brought up during clinic visits with us. There's limited evidence to support many of these nutritional therapies, except for the high-calorie, high-protein diet. However, it's important to meet the patient in the middle and work within their dietary preferences or restrictions as long as they're able to maintain their nutritional status. So, for example, increasing protein intake with beans instead of Greek yogurt because the patient wants to avoid dairy. Reviewing gluten-free grain sources such as oats or rice, or switching to an organic nutritional supplement such as Orgain or Adwala instead of Ensure or Boost. Some believe that heavy metal exposure is linked with ALS. However, the positive association has not been consistent across multiple studies. Alternative therapy recommendations for this include IV or suppository chelation or laxatives to assist with detoxification. High intake of laxatives can cause GI discomfort, cramping, dehydration, undesirable weight loss, and electrolyte imbalances. Some patients also turn to large volumes of vitamin and mineral supplements. This large volume of pills may be difficult to consume given dysphagia and can occasionally cause nausea. Additionally, the supplement industry is not regulated by the FDA for safety and efficacy, and currently there is no evidence within the ALS population to encourage specific micronutrient recommendations. Dominique's going to briefly touch on the current research in keto.
So ketogenic diet is not recommended in the ALS population. The literature shows that most of the research is done in animal models, and there was no difference in outcomes. I think the reason that people look towards the ketogenic diet, that literature show was the high fat content was helping to maintain the weight. So the part of the ketogenic diet where I personally think maybe people don't understand is the high fat portion, like Julia mentioned earlier. So our recommendations are high calorie, high fat, and it's not exactly the ketogenic diet within itself. In addition, the ketogenic diet can actually induce weight loss because you're cutting out all the carbohydrates. So therefore, it's not recommended from that standpoint as well. And we've had some patients try the ketogenic diet within our clinic, and they've come back and they've lost weight. So we don't recommend it here. Oh, that's me. Okay, so conclusion. Those individuals with ALS are at an increased risk for poor nutrition status, which negatively affects the prognosis and quality of life. Early and frequent nutrition assessment and intervention is important in order to work through common barriers, and maintaining nutrition status through early, middle, and late phases of ALS can be managed through diet, oral supplements, or enteral nutrition support.